Good morning, everybody. I'm Dr. Mariam Fadaifard. Thanks for joining. And today we're going to talk about mastering DSAEK and DMEK, tips and tricks for successful corneal transplantation. So, a little introduction about myself. I'm from the Dominican Republic, where I did my ophthalmology residency. And afterwards, I did my corneal fellowship as an Orbis Fellow in the University of British Columbia. So, continuing with a little bit of history, in 1905, Edward Sin did the first penetrating keratoplasty, and it wasn't until 1998 where Dr. Jared Mills introduces the posterior endothelial keratoplasty. But since 2006, there began the shift to laminar techniques that has reduced the PK rate significantly. So overall, DSAEK and DMEK have become the gold standard for endothelial dysfunction. So I'm going to start talking a little bit of DMEK, which stands for Descemet Endothelial Membrane Keratoplasty. So as a poll question, who have done DMEKs in this webinar? Okay, so like 80% of the attendees have done it. Perfect. So I'm going to talk a little bit about who are the DMEK candidates. So the ideal patients are patients with endothelial dysfunction, including Fuchs endothelial dystrophy, which is the most common. Also, the posterior membrane dystrophy, the shed bullous keratopathy, the eye syndrome, and any fell endothelial keratoplasty. There are some contraindications which we can talk about in aphakic eyes, the stromal scarring, if you have a patient with keratoconus, vitrectomized eyes, hypotony, any patient with previous glaucoma surgery or loose sonus. I'm going to start also talking a little bit how I learned to do my tissue prep. And also as a poll question, if any one of you, have you done a DMEK prep? Do you know how to do it? Okay, perfect. So at least like 82% haven't done it. So I will demonstrate today how I learn and how I do it. So first, we will stain our edge of the Descemet membrane with Vision Blue. Then we will remove it with a WEC, as you can see on the video. Then we will fill with BSS to reduce the surface tension, and then we will start scoring the Descemet 360 degrees. Here, I'm using an instrument that is called LASIK microhole and EpiPill. Another method that you can use is the double trephine method. So you can take a 9.5 trephine or a 9 trephine, do your trephine, and then you start your scoring from there. And then you will do the other trephine of the size of the graph that you want. After that I go 360 degrees, then I go again 360 degrees, but moving downward to remove any additions to the stroma. Also, you can use a straight banners just to cut any additions that you have. Now we remove the BSS and we restain. Why do we restain? So we can see the borders of our graph to see if there's any tear. And then we put BSS, and also you can see with the movement if how it's moved and if you have any tears. As you can see in this graph, it didn't have any tears, but you will see like it's staining, and then you say, okay, then I have a tear there, and you have to be careful with that side. Afterwards, I will use the Kalman McPherson forceps to grasp my Descemet until halfway. I will use the biopsy punch to create a small stromal punch. Here, I'm using the 2 millimeters punch. Then the flap is laying back. I go epithelial side, and then we will mark our graph for orientation. I use the F and a dot, but people also can use an S. Then I go endothelial side, and I'm centering the graph to be trephinated to a specific diameter. Then I will punch and go halfway, like middle stroma. As you can see in this reflection, it tells me that I'm already like mid stroma. So I'm good there. Then we will remove the Descemet outside the scoring mark, like we're doing a capsulorhexis. You have to be careful there because sometimes you don't know if you already complete the trephination, and it can be attachments, so you have to be careful there. Other method also you can use to be more gentle is that you can cut with a straight vanus if it works, and then you go like one side and that's it. Now we grasp the graft from a loose edge and peel completely. Everything is under BSS. Now we'll remove the BSS with 2X and we will fill with trypan blue for 2 minutes to stain our graft. So when we insert it in the eye, we can see. Now, after the 2 minutes, we remove our trypan blue, we fill with BSS, and we will align our graft to be loaded onto the gutter glass. But what happens if you have a young daughter graft? The best way you can do is to prepare your graft as a double scroll. So you will like play with the fluid until you get like the double scroll. So when you insert it in the eye, it's easier to unscroll. As you can see now, we have our double scroll. So continue with DMEK, some generals of the surgery, and then we're going to talk about step-by-step of the surgery. Starting with anesthesia, there are several options depending on the surgeon preference and patient factors, but we can use local, subtenon, peribulbar, or retrobulbar. In our practice, we use retrobulbar block for patient comfort. Also very important is to do the peripheral iridotomy, as since it serves as a preventive measure against the pupillary block, allowing the air and the gas bubble to equilibrate between the two chambers. The recommended location is inferiorly, like at 6 o'clock, as you can see on the picture, because this prevents that the air or gas bubble is obstructing the PI, since gas naturally rises up. So if you do it like up, then it will be obstructed. So if you go inferiorly, when the gas or air goes up, then you will have your PI patent. The next question is air or gas? So in DMEK, typically we use SF6 at 20% concentration for graft attachment and lower rebubbling rate. In contrast, for DSAEK, we use air with an 80 to 90% filled. In both, we often check on the slit lamp 1 hour after the surgery to ensure that there's a layer of aqueous fluid that covers the PI, so it tells us that it won't happen a pupillary block. So when it comes to graft size, in DSAEK, typically ranges between 8 and 8.5 millimeters in diameter. On the other hand, DMEK grafts are much smaller, usually around 7.5 to 8.25. So a slightly smaller graft reduces the risk of peripheral detachment and also easy unfolding. Also very important is that the choice of the graft size depends on various factors, including the patient's specific condition and the surgeon preference. In my case, in my school, they taught me that there's like some surgeons uses 8, like as a like always 8 size, but you can also measure like the gutara vertically and horizontally, and depending on that, then you can choose which size of the graft you're gonna do. So in this image, I want you to see that when you load your graph, it's very, very important to see this V sign. These V signs tell us that is the right orientation because the DMA scrolls endothelial side up. So when you go inside, you always have to be sure you're seeing that sign. And also you have to ensure the orientation mark if you are using an S or an F. So starting with the step 1, if it's after cataract surgery, after the IOL implantation, I will mark my cornea with the caliper with the desired size without removing the viscoelastic, and also I mark my paracentesis at this stage. You can do one inferiorly, that will be for the AC maintainer, one nasally, and one superiorly, and you already have your main incision here. Step 2, the Descemet. So you will use the reverse Sinski, and also it helps me using the red reflex illumination for enhanced visualization. Very important here is not to press in too hard because you can cause stromal damage. Step 3 is to inject trypan blue, and then we will re-inject viscoelastic to help visualize if we have any residual Descemet. In this case, we don't have any residual Descemet, so now we will use the terry scraper to polish the stroma 360 degrees. What this does is that it roughens the surface for better graft attachment. So now we'll remove the OVD. We use IA to thoroughly remove the cohesive viscoelastic. We go behind the IOL and into the angle to remove any trapped viscoelastic. This is important because any retained viscoelastic may block the graft from adhesion. Step 5, meiosis induction. So we will inject, you can use Myoclor or Myostat to prepare the eye for the insertion of the graft. This will reduce the risk of the graft to slip in posteriorly during the insertion. Step 6. As I told before, you are going to use the AC maintainer placement inferiorly. And it has to be bevel up, as you can see there, bevel up. Step 7, graft insertion. So we will insert the DMEK with the gutter glass beveled down, and then we will adjust positioning until we see the V sign. And then once inserted, we'll remove the AC maintainer, and how I demonstrate on the video, we will apply counter pressure on the main incision to prevent the graft to prolapse. Let me see. There, I'm counting counter pressure. Next, we're going to start the graft unfolding. So gentle will do corneal tapping to help the graft unfold and center itself. I brought here some unfolding techniques that I use during my fellow. The most common one is that the Descemet technique. Here, you're going to use two cannulas. So here in this picture, you see the red cannula will be stationary and mildly compressing the cornea, and the green cannula will be using like a sweeping motion. So you can open the scroll portion of the graft. Also, you can use the golf strokes technique if you have your graft in the angle or in the limbus. So you will do quick strokes at the limbus with the cannula to generate like a fluid waves that will move the graft forward away from the limbus. Other technique is central tapping. So when you have your graft in, you can tap on the center along with the long axis of the graft of the scroll, which will generate a fluid wave that will unfurl the graft from the center outward. And also we have the perpendicular tapping. So here you will try to tap perpendicular on the graft of the end of the scroll, and this will send fluid waves into the scroll to open it. I really like this technique. It's like compress and release. So you will compress the graft, the cornea, with the cannula, and on the other, you will put the cannula onto the paracentesis. So the graft will go where the fluid goes, as you can see on the video. When I put the fluid, it will move. I will try to open. And also we have the walking technique. Here I'm using two cannulas to move the tissue by using small, gentle strokes with alternating hands to shuffle the graft forward. Something also that it's new kind of. If the scroll is tight, you can use this instrument. It's called the DMEK Fogla cannula. So you will insert it on the scroll, and this will release fluid from side to side, pushing the graft to open. So after we unfold and center our graft, next step is the gas injection. So here we will introduce a tip of a cannula with 20% SF6 into the anterior chamber, just posterior to the graft. We always have to make sure that we are going posterior to the graft. And finally, we will hydrate all our wounds, and we will leave the anterior chamber between 80–90% fill of SF6. After the procedure, the patient will have to lie supine as much as possible, at least for the first 3 days, to utilize the residual bubble into the anterior chamber. So here we're gonna talk about like some complications, being the graft detachment the most common and the early postoperative complication. This one is usually detected on the slit lamp, as you can see here on this picture. You will see this. And also you can confirm it with the anterior segment OCT imaging. So if the detachment is less than 1/3 of the graft area, you can observe to see if it attached by itself. But if it doesn't, then you have to rebubble, and you can do it on the office. Here you don't have to use SF6 again. You can use the air with the 30 gauge cannula. Then after that, you have to tell the patient that he has to lie supine for at least 1 hour. And then after that, you have to check them again to see how's the bubble and to prevent any pupillary block. Also, what happened to me while I was trying to learn is that fibrin can sometimes develop into anterior chamber, making it difficult to unfold the graft and form you are trying to unfold it and you can't, like it won't move. In this case, we use as a salvage solution TPA, and after 10 minutes, you can see on the OCT that the fibrin was reduced, so it can let us unfold the graft. But to prevent this, I recommend using the enoxaparin. So what I learned is that you can inject 40 milligrams of enoxaparin into the BSS, not into the ACs, on the BSS. And you will start your surgery normally, as you will do, and everything normally. But I learned that using this, I felt that the graft opened easier. And also, like, studies have suggested that the enoxaparin imparts like a negative charge to the graft, so it facilitates scrolling. So we're going to move on DSAEK, which means Descemet stripping automated endothelial keratoplasty. And as a poll questions from the audience, have you done any DSAEK? Okay, perfect. So 77% of the audience haven't done any DSAEK. So what is a DSAEK? DSAEK is just a partial thickness graft that contains the endothelium, the Descemet, and a thin layer of a stroma that you will transplant on the eye. So the common indications for DSAEK is as the same as DMEKs for endothelial dysfunction. That is the underlying cause of vision loss, and being fused dystrophy, the most common one. Also, most of the patients that we use the DSAEK is with patients with PBK, or if you have like a failed previous graft, or endothelial failure after PK. Other complex cases can be vitrectomized eyes and the tube shunt. So starting with the preparation of the donor cornea, the donor cornea is performed with the assistance of an automated microkeratome by eye banks. So here they will take the corneal scleral rim, and we will mount it into the anterofascial anterior chamber, which is filled with PSS to protect the endothelium. Afterwards, they will measure the pachymetry of that cornea to decide the appropriate microkeratome blade thickness. So after that, they will use the microkeratome, then we will be passed through the cornea to create a lamellar dissection, leaving the residual bed in the range between 100 to 180, which constitute the DSAEK graft. Also, they are now doing nano-thin DSAEK graft that are like 50 microns thick. So you will receive your corneal scleral rim, like already with the bed done. So some surgeons mark the graft to help with orientation, and afterwards, that trephination, we will load the graft into the inserter. Here, I'm using the one that is called Macaluso inserter. And here, I'm using the MSD forceps. So here in our surgery, after doing our descemetorrhexis, we enlarge our wound between 4 to 5 millimeters, and we'll insert our AC maintainer inferiorly, like in the DMEK. And then we'll put 2 sutures in the main incision that we will tie it after we insert our graft to protect the graft to go in forward. After that, carefully, we will insert our graft into the appropriate position, and then we'll tie our sutures. After the graft is positioned carefully, using a variety of brushing and sweeping techniques, we inject air and we wait 10 minutes in the OR. And after that, we will check again and see how, like, the percentage of our bubble, and if we need to put more air or if it's okay, and then we can send the patient for lying supine for 1 hour to see them again. So I will now show some tips that I learned. The first one being, when you have a vitrectomized eye, what happens is that the bubble goes to the posterior chamber. So we have to make sure that the graft stays in place. What we do is that we place a superior suture that will hold our graft there. So if there's a detachment of the graft, right, and it will hold with that suture, and you just have to rebubble in the office. And tip number 2, and I think the one that I love the most, is the use of the STC6 needle. So first you inject air, and then you take a straight needle, the STC6, right? And insert your needle through the cornea until you touch the stroma of the graft, and you move it to the direction that you want. What I like about this technique is that you don't touch the endothelium, so you won't have endothelial cell loss. And another tip is you can take a 30 gauge needle, you bend the tip, and you go in. Touch your graft only in one position, because in that position you will have endothelial cell loss, and move the graft, and then when it's in the right position, you will inject air. So passing on some complications that can happen during DSAEK. Some studies suggest that primary graft failure, it can happen between like 5.7% of the cases. And in many cases, the graft fails to adhere because of the surgeon was aggressive in handling, and it had damaged endothelial cells. Also, it can happen the graft dislocation, that the graft moves from its intended position. So this is generally treated, taking the patient back to surgery to reposition. Also, if you think the patient can stay on the strip lamp, you can also use the technique of the STC6. You go in, put air, and then with the needle, you move the graft to where it should supposed to be. And another problem can be interface haze, or also referred to as textural interface opacity. So this happens because there's retained viscoelastic between the graft and the stroma, right, of the donor. So this complication usually resolve between 6 to 12 months. Something very important to keep in mind is the hyperopic shift. So multiple studies have shown that DMEK can cause a mild hyperopic shift of 0.5, while DSAEK can cause a hyperopic shift between around 1 due to the shape of the donor tissue. So if you're gonna do a patient with cataract and a transplant, you have to aim for choose the lens more negative so you can compensate the hyperopic shift. And as an extra, I bring today Descemet stripping only or the DSO. So this procedure is only indicated in patients that has guttae within 5 millimeters of the central cornea with clear peripheral cornea, and that they have endothelial cell count more than 1,000 cells. Some of the contraindications of the DSOs are the presence of Descemet membrane folds or any stromal pathology. So here's a video of a DSO. So the best way is using the peeling technique to maximize the cell preservation and migration. So after we mark our cornea in the video, right, we will take the Versinski side-by-side movement to create a small Descemet membrane tag. Then we'll pick that tag with the Gorovoy forceps, and we'll create like the Descemet we will be propagated in a circular motion to the area that we mark. So this technique, we don't use like we do the Descemet and the other and DMEK and DSAEK, because when we do the when we create the Descemet, we create this trench in the stromal, so this will be prevent the migration of the endothelial cells to that area that you want to repopulate. So the postoperative treatment should include topical steroids, antibiotics, and hypertonic sodium chloride. But recent studies have shown the use of Rho kinase inhibitors that can increase endothelial cell proliferation, and it has shown better outcomes. So what are the ROCK inhibitors? This has been demonstrated to aid in the repopulation of the human corneal endothelium. So what we're using right now is the one named Ripasodil at 0.4%. That this one is commercially available in Japan for the treatment of glaucoma. So this will cause is the increased cell proliferation and addition with subsequent decrease of the apoptosis, which in this case will increase the endothelial cell density. So the great advantage of DSO is the elimination of the donor tissue implanted in the eye. This alone will prevent postoperative complications involved in DMEK, such as graft rejection, potential IOP spikes, and the use of prednisone like for a whole their whole life or most of the time. Regarding disadvantages, there is a long healing period compared to DMEK. You have to wait at least 6 weeks to see if there's any improvement on clear of the central cornea. And also it can cause ghosting and irregular astigmatism that have been observed, and also stromal trauma that can produce an irregular posterior corneal profile. So these are like my personal tips and steps for learning DMEK and DSAEK. I hope you find today's sessions helpful. And I think if there's one key takeaway, I would like to emphasize the use of the STC6 needle. For me, it has been really like a game changer in DSAEK for moving the graft. But if you have any question, you can also feel free to contact me. Here's my email, and I'm happy to help and answer any inquiries that you may have. And thank you. Okay, so I have a question. Have you had any retina problem post-op like VMT due to repeated shallowing during graft manipulation? No, from the cases that I have done, I didn't have any retina problems from the shallowing of the AC. So if a patient peripheral cornea is also affected, then what indication is possible? So it happened that sometimes you can have corneal edema, like peripherally. It can resolve by itself, but also you can use the Ripatril. Like I talk in the DSO, you can use also Ripatril in doing DSEK or DMEK, doesn't matter, because it will, like I show, it will help you repopulate that area if you have like the peripheral edema. What happens is that if you have your descemet more larger than your graft, that in that area you will have peripheral edema. So that's why you can use the Ripatril. So next question is, if I do a DWEC, DSO, and it didn't work, can we do a DMEK later on? Yes, you can do a DMEK later on. So if you have your DSO of 4 or 4.5 millimeters, right, then you have to stent your descemet, and then you can also do like a 6 millimeter DMEK graft or 7. It doesn't matter, like you can decide. My email is, well, I think they will share my presentation and you can see it there, so you can write it down. And the next question is, do you ever prepare your own DSEK graph? If so, the DSEK graph, you will need the automated macrokeratome. So the DSEK graph is the IBAN that prepared it themselves. You can just see the thickness of the graft, and then you can decide like about the surgery. So what is the graft failure rate for each of the techniques? So DSEK graft failure rate is like 5.7. And also DMEK is like 3 to 2%, because since it's thinner, it won't cause the immunologic reaction that can cause the primary reject failure. I'm here. How much do you adjust the graft size based on Gute? So let me see. You have to dilate your patient, right? And with retroillumination, you will see the guttae, and then you will, with a slit lamp, measure vertically and horizontally. Where are the guttae? So it can be like 5, 6, 7, 8. So if it's 8, then you know your graph should be the size of 8. I don't know if that answered your question. Could we repeat the procedure if it doesn't work at the first time? So if we do a DMEK and it doesn't work at the first time, you have to see how much of edema your cornea have. Because if you don't see much, then you have to do a DSEK. But if it's clear or something, then you can repeat a DMEK. But if it doesn't, you have to do a DSEK because you don't have proper visualization of the AC, and for the tapping and everything, it's gonna be difficult. The youngest age for DSEK or DMEK. But you mean for the graft or for the patient? If it's the graft, DSEK doesn't matter, because since DSEK you have a thin layer of stroma, it's gonna be thin, and you don't have to unscroll, then it doesn't matter the age of the graft. But for DMEK, yes, because if you have young donors, then the scroll will be very tight and it will be very difficult to unscroll during the surgery. So for DMEK, we probably use 45 years old donor, the graft donor. And what is your opinion on the need of doing the PI in this case? So in my case, in my school, we always do the PI inferiorly. It doesn't matter, because we want to prevent the pupillary block. It happened once that the PI was mildly patent, so the patient did had a pupillary block, so we had to go to the office to release some of the air. Do you do the PI appropriately or intra-op? So we recommend doing pre-op with the YAG and the laser. It's easier, you don't have any complications, because if you do it intra-op, like some surgeons do, and it's okay. But if you do interrupt, it can happen that you can cause a little bit of bleeding, and that bleeding can interfere in the addition of the transplant. Mm, I think there's no more questions. I appreciate your time and thank you so much for listening. Oh, I have another question here. So which technique is better for bullous endothelial keratopathy? Like I was saying, in BBK patients, it's like the visualization of the AC is very difficult. So in those cases, for example, in my school, we always did DSAEK, because for DMEK, if you don't have very good visualization, then you won't see where are you unscrolling your graft. And how long do you treat DMEK with steroids? So for the first year, I mean, you do at least 3 months, 4 times a day, and then you will reduce it to 3 times a day until when you are in 1 year, you reduce it to once a day. So in DMEK, since it's just like a thin layer, you probably can take that off. We usually wait between 2 years that we see that everything is okay and it hasn't present any graft rejection, and then you can just put it like a 1 day and then the other day like off, and that's it. There's a question. How do you prevent the bubble to go behind into the vitreous while injecting the SF6? So I'm guessing this is a vitrectomized patient. So in vitrectomized patient, even though you put the bubble, it will go to the posterior chamber. So that's why we prefer doing DSAEK in vitrectomized patients. So you do the suture, superior suture, like I showed in the video, than doing the DMEK, because in the DMEK, since it's a thin layer, then even the graft, like if it's on scroll or anything, it can go to the posterior chamber. Is there any role on cyclosporine? Um, I myself, I didn't use cyclosporine in those patients. I already answered that. Mhm. What technique? I already answered that question about the PBK, but for PBK, DSEK, because you won't see much. So you always go DSEK for PBK. It is important to mark the DSEK graft. So I think this is more of the surgeon preference, because since you already know, like since it's a thick graft, you already know, you can don't mark it. But for reassurance, we prefer to mark just to make sure that we are on the right orientation. And how is the learning curve? So I think for the SEC is more rapid learning curve, because you just have to learn how to pull the graft inside. But for DMEK, it's a little bit more difficult just because of the unscrolling techniques that you have to learn, and also like the perseverance, because it's not always gonna be good. And also you will have difficult cases that doesn't want to scroll. For example, the case that I show about the fibrin, when you are learning, every time you tap, right, the iris can create fibrin, like, and that will like the fibrin won't help you like unfold your graft. So that's why I think DMEK is a more harder learning curve. if we don't have availability of tissue, can we do DSO in PBK? No, because in PBK you already have corneal edema, like the whole cornea is not a portion. For DSO, you only have to have a portion, like central portion of edema, like maximum 5 millimeters of edema. And if it doesn't work, because in 9 out of 10 patients, DSO works, but in that one patient, if it doesn't work, then you have to do a DMEK or a DSAEK, which one is available in your country. Do you use oral steroid for any cases and for how long? So in my cases of DSEK and DMEK, we didn't have to use oral steroids. We only use oral steroid for a patient with PKP because he was presenting graft rejection. But for DSEK and DMEK, we didn't use oral steroid. And how many procedures were you able to do before being confident in 8K? I think for DMEK, I had to do at least 10 so I can feel confident about it. And any instruments that you will recommend that we invest into practice of EK. So for DMEK, if you're not gonna do the donor prep, then you just need your Reversinski, and you can also help with the let me see, Traversinski, and then the cannulas, two cannulas. Like the DMEK, you don't need much of instruments. But for this sec, yes, because you need the MSC forceps to pull the graft in, and also the inserter. There are different inserter available. In my case, I learned with the Macaluso that I show in the video. But you can use the boosting glide, or that one is cheaper also. So I will do the boosting glide and the MST forceps. What will happen if you put the graph grown side up? So if the graph is the wrong side, if it's a DMEK, then it will scroll back because it always scroll in the two side up. And for example, there was a case that it was the wrong orientation. So at the next day, the graph was in the AC. So we have to pull that out and put a new one. Um, six. I didn't understand the last question. I think that's it. So thank you so much for listening, and I'm available with my email. You can reach out. Thanks.